This week on the Backtable Podcast.
In our emergency department, our main hospital, the triage is staffed by either one of the ER attending physicians or an advanced practitioner, and any of them, whomever's in the triage area, can sound the alert. Let's say the frontline provider is unsure if it's acute limb and they curbside one of us. We have enacted the alert because the importance of the alert is to expedite the care. But as we're monitoring this prospectively, when it gets sent out through the paging system, it also gives us that little reminder of, let's sure this patient is going into our research prospectively. Let's make sure we have eyes on them so that we can report on our clinical outcomes. And we've all embraced, Sabine, the endo first approach. And so if their anatomy and their prior surgical history, if it allows for an endo approach, again, we're embracing that use of penumbra and the computer-assisted vacuum thrombectomy.
Hello, everyone, and welcome to Backtable, your source for all things endovascular and more. You can find all of our episodes online on any platform you prefer, like Spotify, Apple Podcasts, or directly through our website, backtable.com.
Now, a quick word from our sponsors.
Penumbra's Lightning Flash is the only computer-assisted vacuum thrombectomy device on the market to address venous and pulmonary thrombus. Featuring Lightning's latest microprocessor, Lightning Flash uses both pressure and flow-based algorithms to detect thrombus and blood flow. The Lightning Flash catheter is made with Max ID HypoTube technology, allowing an inner diameter similar to large bore catheters while maintaining a low profile. When it comes to thrombus management, Lightning Flash is designed for speed, safety, and simplicity. Product availability varies by country. For the complete Penumbra IFU summary statements, please visit peninc.info/risk. That's peninc.info/risk.
Now, back to the show.
I'm Sabine as your host today, and I'm happy to welcome Dr. Charles Bailey, who is a vascular surgeon and big man on campus as the director of the PAD and limb salvage program at the University of South Florida. Welcome to the show, Charles.
Sabine, afternoon. Really appreciate the invite. Looking forward to the discussion.
For sure. Now, we've discussed acute limb ischemia on the show before, episodes 118 and 315 for our listeners, but we haven't talked about this really neat program that you've created about the Limb Alert. We're going to delve into that too in a little bit, but first, can you tell a little bit more about yourself and how you landed up in Florida?
So I'm a Michigander, natively born and raised in the Detroit area, and education and training just took me to the South. So I went from college and medical school in Michigan to Atlanta for residency training, then subsequently to here in Tampa for my fellowship in vascular. And I think, like a lot of people in medicine, you get to the point where maybe you're tired of moving, or you build good bonds and mentorship, right, in the places you train. And I've spent the last now 12 years here in the Tampa market.
That's awesome. And can you describe a little bit more about your practice? Do you focus on endovascular? Do you do more open, or is kind of a mix of both?
Yeah, so here at the University of South Florida and Tampa General Hospital, I'm one of the vascular and endovascular surgeons. So board certified, fellowship trained in vascular surgery. And my practice mix currently is, I'll call it all arterial. So it's a mix of carotid, aortic, peripheral arterial disease. And as you mentioned in the intro, I've been put in charge of our limb preservation and peripheral arterial disease program. So I'd say the bulk of my clinical practice is managing both acute and chronic arterial conditions.
Got it. Yeah, BMOC, as I called you. All right. And at the University of South Florida, who treats acute and chronic limb patients? Is it all vascular surgery, or is it a mix between vascular surgery, IR, and how does that all work?
So I think here at USF and Tampa General, what's really nice about our health institution is it's a real blend of the university practice, which I'm part of. The Tampa General Medical Group has its own independent practice, and we're merged in many aspects. And we also have a private practice component to the community. And so for peripheral arterial disease and the chronic side, you get a blend, largely vascular surgery, but a blend of vascular surgery, our solid interventional radiology group, and some local skilled interventional cardiologists. So it's a mix. For what we're going to talk about today when it comes to the acute limb, that is 99% our vascular surgery group. But we do have a fantastic radiology group we work with from time to time, patient to patient.
That's awesome. And how many people are in your practice?
So we have a principal group of 7 vascular surgeons
Okay.
and the interventional radiology group, which again helps us with our complex aortic and our peripheral arterial disease acute limb patients, is a mix of around 7 IR docs as well.
That's awesome. So it's a good mix. You've got kind of a hybrid practice with academic and private. Like it's the dream. So that's great.
Very collaborative, which is really important.
That's amazing. So acute limb ischemia, we're not really going to go into technique today, but we're going to be talking about everything leading up to the technique and then just talk about technique a little bit. But how acute is acute limb ischemia?
So by definition, it's 14 days. And as you and I know, and a lot of the people in our audience here, it's largely a clinical diagnosis. So the patients who present with, from few minutes or hours to up to 14 days of any of these classic ischemic symptoms, right? We all learn in medical school the 6 Ps of ischemia, the pulselessness and the pale, et cetera. I've dubbed a 7th one, which is prior vascular interventions, because the 7th P, right? Because a large percentage of our acute limb are people who have had an endovascular or an open revasc that has subsequently failed, right? And so largely a clinical diagnosis for acute limb ischemia. And that 14 days is something we learned from one of the original randomized trials, right? That catheter-directed approaches, catheter-directed thrombolysis was more effective if it presented within 14 days of these symptom onsets. And so that's kind of set the benchmark of from day 0 to day 14, if you have these symptoms, we consider you an acute limb.
Definitely. A big question people always have is, can an acute limb ischemic patient, can you wait overnight, or is it something you have to do? Like, is it like a stroke or a STEMI where you got to do pretty, stat?
I think the question of when and can we wait and should we wait is something that we're trying to assess. And I think it's something that's in need of really reappraisal. When you think of acute limb ischemia and you look back over the last 20 years since the randomized trials, the key metrics we look at, mortality, amputation-free survival, limb salvage, in this, endovascular revolution really haven't changed. And I know you and I and others who treat the conditions probably aren't providing poor care, but maybe it's, that notion of can we wait? Does that really mean should we wait? And so that's one topic we've hoped to answer, and it's what's really driving our hospital-specific protocol for these patients.
And especially with the change of technology, 5 years ago, really we had one option in an endovascular approach, and now we have so many. When you get the call about a ischemic patient, what are some of the key questions you ask?
So the way our protocol for acute limb is set up, it's a system-wide protocol. At the point of triage, it's asking those salient clinical questions. How many days have your symptoms been present? And really keying in on those, the 6 Ps of ischemia and the 7th P of prior intervention. So it's a clinical diagnosis. So we're really trying to pin down as best we can, do these symptoms really fit with someone who has acute limb ischemia? Because there are many conditions, musculoskeletal, lumbosacral disease, even some chronic conditions that can mirror it. So it's really honing in on those 6 Ps of acute ischemia, the 7th P of prior intervention, and then really, really as best we can, trying to pin down, is this really an acute within 14 days of onset symptom?
Sure. Yeah. And then what about clinically, to kind of tell you how soon you have to treat the patient? Is there any specific, things you ask the provider? And then a follow-up to that is, what if you don't trust the provider that's talking to you?
Oh, I'm going to work backwards on this. So patients are not always the most reliable, maybe not the most medically literate or tuned into healthcare. And we get a lot of frontline providers that may just have never dealt with a vascular patient or an acute limb condition. And so when you look back at the algorithms that are published in the management of acute limb ischemia that break down after that initial assessment, the Rutherford classification we use, whether it's a 1, a 2A, 2B, or a 3, no algorithm and no table really specifies when you should intervene. We all kind of understand that a class 1 has time to wait. It's more of a subcritical, more of a chronic. You have time to evaluate and assess the patient before you revascularize, but even that doesn't have a timestamp. And the 2As and the 2Bs, we think of them as marginally and immediately threatened, respectively, there's not really a time stamp. And I think if you surveyed, 100 vascular interventionalists, regardless of specialties, and you ask them when they intervene on a 2A, for example, so someone who presents with acute limb ischemia, but without any motor deficits and maybe a slight sensory change, you'll get 100 different answers as to when they respond. And so we've embraced this, again, learning from the lessons of stroke and STEMI. We're embracing this. Everyone gets treated rapidly, regardless of class, so long as it's safe for the patient. And if you look back, Sabine, at the stroke and STEMI protocols, time is brain and time is myocardium. And we know with acute limb that delaying care and or delaying that time to revasc does increase the risks of ischemia and reperfusion injury, which is a systemic insult. Our patients come in kind of dire straits. And so waiting, in our opinion, our clinical practice experience, waiting to revasc does lead to higher subsequent, post-intervention outcomes. And so you come in, you're going to the OR as quickly and safely as we can get you there.
That's great. And we all know about the complications like bleeding during the procedure or something like that, or a groin complication, but you kind of alluded to it, compartment syndrome. Why does compartment syndrome occur, and how often do you see it in these patients?
Our practice here in our community, we have such a large catchment area, and I'm sure it's not too different from many parts of Southern California, where we are taking patients in transfer from facilities, 10, 20, 30, 100 miles away. And you add in that time to revasc or time to care with maybe a cloudy history from the patient or an uncertain timeline from the referring doctor or the triage physician, that you might think someone, for example, is a 2A, but you put in these little doubtful, these little seeds of doubt of, well, was it really that long? Is this really when it happened? And we found that many patients are actually more ischemic than their initial clinical presentation would suggest. And so compartment syndrome, we see it not infrequently. We are definitely not a program who sees it in a delayed fashion after a revasc, because we are very pro fasciotomy for the advanced ischemic states, the 2Bs, and decompressing that compartment. And the reason we've embraced that, Sabine, is there is plenty of data to show you that if you miss a compartment syndrome, or if you have to do a fasciotomy later and there is dead muscle at the time, the limb loss rates are through the roof. And the amputations is not 100%, but it's really close. So compartment syndrome and being really, I guess, as accurate as you can in diagnosing that ischemic state up front. And if there's any doubt as to how they ischemic, maybe level them up from a 1 to 2A or 2A to B, erring on the side of it's worse, has really helped prevent, limb loss by, again, trying to be as accurate as possible and really embracing a rapid approach to revasc and prophylactic fasciotomies as needed.
That's great. One of the things that we see too is that these patients are way more ischemic than they present, just like you said, and combination of poor history or even a provider just saying, yeah, the foot's cold. Like there's not that much history, especially in the community, right? When you look at that angiogram, you get really surprised. I mean, it takes like 20 seconds for some contrast to get down to a reconstituted pedal or something like that. And you're just like, wow, how is this foot even
how is it still intact or have any motor or sensory function?
What are some clinical signs you look for that tell you that it's not salvageable? Are there any legs that you just say, okay, we're going to go for an amputation rather than revasc?
So the class 3 in the Rutherford, those patients who present with almost a paralyzed, paretic, contracted, fixed leg from a prolonged ischemia, those are really hard to salvage, right? When nerves are very resilient, and in even someone who presents with a foot drop in an earlier stage of ischemia, they can recover with time. But you will have these patients where the ischemic insult is just so severe or so prolonged that they're insensate. They have a fixed ankle, a fixed knee, a contracture. They may already have skin changes, blistering, mottling, etc. And the challenge with those patients is, yes, you and I and others, we could put them through a procedure, we could open up a blood vessel, but you're not going to save the leg. And even if it's a healthy person without a big, burden of comorbidities, the damage is done and time matters, and muscles and nerves are resilient, but to a point. And so it's that class 3 group. And you have to temper that with a lot of these patients are not the young and healthy athletes of the world. They're men and women with a high burden of comorbidities. And so revascularizing those advanced stages is just going to lead to a greater ischemic reperfusion injury, a greater, risk of adverse systemic events to the brain, the heart, the lungs, kidneys, etc. And so sometimes it's that very difficult decision of, well, we could revasc, but yes, Mrs. Jones here with advanced heart failure, right, and a history of, yes, you won't like the after effects of a revasc.
Yeah, totally agree. One of the questions I sometimes use, my partner taught me when I started, is, can the patient push down on their foot like a gas pedal? Like if they can do that, if I get the call overnight, I kind of feel a little bit more at ease that I can do this in the morning. Or if they're really losing that sensation, that's something I'm like, okay, or they're losing that motor function. That's pretty telltale. And if it's completely gone and it's modeled, then there you go. You got your class 3 patient.
And I think it's important to don't look at the foot or the leg in isolation. Compare it to the other side, because we see, an elderly infirm, someone coming from a rehab facility, or someone who may have not been out exercising on a daily basis. Maybe they have weakness to both legs, and what you're seeing on one side might be the same that you have on the unaffected limb, and it might give you a better understanding. You may not be as concerned about their ischemia to the clearly affected, clearly ischemic leg if they have the same chronic, muscular weakness. And same as you, I have them push down, gas pedal on a clutch, not that anybody uses a clutch anymore, and move both feet and assess that. And I think the other kind of pearl I'll throw in there, Sabine, is motor function matters, sensory function matters, skin changes, but in that ischemic progression, the last thing people will have is muscular tenderness. And so I've taught my residents and fellows, you're examining someone, they may look like a 1 or 2A, something that's mild, you have a little bit of time. But if their calf muscle, if their anterior compartment, or if it's a thigh ischemia, if their muscular compartments are tender, in my experience, they get a level up in their ischemic state. So if your calf is tender when you come in and you're a 2A based on your foot exam, but your calf is tender, yeah, you're a 2B. That is a sign of more advanced ischemia than the patient is showing you.
That's good. That's a pro tip, actually. Yeah, that's something, the tenderness. I mean, sometimes it's pretty severe. You'll see you just squeeze the calf and they just scream, and you're like, whoa. And of course the foot's cold and everything. That's going to revasc. So speaking of revascing, a couple traditionally, what would you be doing? Is it open, surgical, before the advent of some of these new technologies?
So we practice a blend. Our patient population is such that our average PAD patient is not the first time SFA stent or the first time femoral endarterectomy, right? As the academic institution here at Central Florida, in my practice speaks to this, it's 3rd time bypass, 4th time bypass, right? Hostile anatomy. And so we see a lot of patients where just their anatomy, where their surgical scars are, prior fasciotomy, may not lend themselves to a technically feasible endo approach. So we still have to rely on that open skill set. But we have really, as medical, records will show, we've really embraced an endo first approach. And historically, if you look at, VA and Medicare data sets in the last 2-3 decades, we've had this increasing use of endovascular technologies for acute limb without the expected improvement as we would think or hope to see in outcomes, right? Mortality and amputation-free survival have kind of been a stagnant flat line, which is, right, allowed us to question whether we're doing the right things up front, whether the technologies we've had historically. But we've embraced all, and I think in treating acute limb, regardless of your specialty, you have to have access to all those tools because it's not one tool for all jobs. And as a vascular surgeon, we're lucky because we're trained in all techniques. But I have friends and colleagues who are radiologists and interventional cardiologists where this is a big part of their practice at their institution. And so, if that's you, you just have to foster those relationships with someone who can, wield cold steel if needed when the endotherapies aren't effective. Yeah.
I have to say it's, I sometimes scrub in with our vascular surgeon on some cases just to watch. And there's nothing like seeing that Fogarty balloon being pulled back and these like Tootsie Roll clots are coming out, and then you just get this fountain of blood. It's pretty remarkable and way different than the black and white endovascular approach when you see it. It's pretty remarkable.
As a vascular surgeon, acute limb and limb-threatening conditions is what got me interested in the specialty to begin with. But surgery may not be the answer, right? When you look at historical numbers of open thrombectomy and open embolectomies and what many surgeons and the old guard might see as the traditional status quo gold standard, it's imperfect. And it still has that open technique of mortality rates of 20% in a year, amputation rates up to 25%, with data that is not as promising or supportive as some of the newer endo first approaches we have.
Yeah, speaking of, how has the technology changed, and how has that changed it sounds like your practice has become endo first a lot and maybe due to technology.
So as someone who really thinks about acute limb ischemia a lot, I've bought into the idea wholeheartedly because I've seen it in clinical practice that debulking matters. And we all know this, right? The principle of acute limb is get the clot out, restore perfusion. And historically, when you look back at the randomized trials between open and endo, a lot of people interpret that as being clinically equivalent. That's 30-year-old data with one endo device being a lytic catheter using urokinase that nobody uses anymore.
What the hell? Yeah.
Right? And so, again, learning from Stroke and SEMI and other centers who have developed fast-track protocols in managing these acute conditions, we've developed a fast-track protocol for acute limb. And the cornerstone of that is using some of these newer technologies, especially aspiration thrombectomy and the computer-assisted thrombectomy from Penumbra, to rapidly debulk, restore flow, show you the culprit lesion, allow you to fix it if you find something. But also, if it's someone with an advanced multi-level disease, doing this, newer techniques with the aspiration thrombectomy and embracing that technology has allowed us to really effectively not only debulk, but show us the landscape, show us what the underlying culprit lesion is, and allow us then to make the best decision for how to treat that. Because it may not be an endo solution, depending upon someone's anatomy, but if you've debulked them and gotten them out of the woods, then gives you time to be a little more thoughtful in what's the right choice to fix them.
Exactly. You can restore that flow quicker, even if you have to lyse afterwards. Debulking it, obviously makes sense. You'll have less clot to disintegrate and break up. Even in the last 8 years, I've seen so much changes with suction thrombectomy. Back in the day, we had Indigo. Cat 6 was thought as like a big catheter, and went all the way down to Cat 3, and now with this computer assisted, what does that mean? How does that work in your practice?
So when you think of the endo approaches we have for acute limb, and for those of us who embrace the endo first, it's embracing this idea that you want to debulk, restore flow, open up pathways, preserve the collateral beds. And if you're going to take the endo first approach, I think we all have to temper that with not only providing what is a safe and durable and effective treatment, but also a therapy that has the lowest potential risks of complications. And we've all had the thrombolysis patient that developed a retroperitoneal bleed and require, or an intracranial bleed, and then you're kicking yourself the next morning if that was the right choice. And we've all had the patients with some of the other pharmacomechanical devices where distal embolization, and instead of preserving those capillary beds, we trash the foot, so to say.
Yeah.
Right. So we've really embraced the Penumbra and the computer-assisted vacuum thrombectomy as the best option for all those reasons, because it allows you a really rapid debulking of all lesions, allows you to minimize the chance of distal embolization, because if there is a piece of fragment that moves, you can just aspirate it back out, right? And that's a rarity. And also it, really keeps that need for something more risky like thrombolysis in your back pocket. And you'll still have those patients that need an adjunctive therapy like a lysis catheter if it's a deep tibial occlusion that you just can't aspirate out, or if the foot has a burden of thrombus. So what's really nice to being about the device, and I'm sure you and I remember days of just putting a catheter in a large syringe and just pulling back on negative pressure and hoping you engage the clot. What's nice about the newest technology, it's really embracing technology, modern tech, augmented intelligence, using a computer assistance to be more effective. And so the device, not to get too much into the nuts and bolts, once you engage the clot on the engine, the aspiration canister, you have audio and visual, you have haptic feedback for when you're aspirating, when you're engaged, when you've cleared the clot. The machine itself will aspirate and augment its pressure such that if you have the thrombus stuck, it'll augment its pressure to help rotate it, move it, fragment it, like the good old-fashioned separators used to do, just in a more streamlined manner. So we've really embraced that as our go-to first line, apply to anyone who is able approach.
That's awesome. One question I have for you is, how do you remember the names? We used to call them CAT, whatever. Now it's Bolt and there's Flash. How do you remember the names? Because I'll sometimes tell my rep, like, get me the CAT 7. They're like, no, it's the Bolt. I'm like, okay, I don't care what it's called.
It's easy for us in Tampa because our hockey team is the Tampa Lightning, also known as the Bolts. So we had this natural, the branding, I guess, was built for us. So it's very easy for us to remember that the newest generation is the Bolt 7, using, their CAT 7 aspiration catheter. We have Flash and Lightning. There are lots of products that are really effective on both the arterial and the venous side.
Yeah. I just sometimes get confused with the names for us in Cali,
I think as their product has evolved, the names have gotten a little shorter. So the Bolt is the newest one, which is the one that really embraces on the arterial side that, computer-assisted vacuum thrombectomy. And yeah, it's an automated separator, as I like to teach and tell people.
That separator was pretty annoying back in the day. I didn't really, know how to use it except just cause some distal emboli at times.
I think the approach to acute limb, if you're going to do an endovascular, again, not all tools are perfect. Not all tools fit all anatomy. And this rings true for any interventional site, be it heart, peripheral, brain. And I think with all devices, you have to be patient. You have to have a broad skill set. And I think with any surgical approach or interventional approach, it's not so much the act of inflating a balloon or passing a wire catheter that makes these things successful. It's the troubleshooting. It's thinking forward, playing chess instead of checkers. And so there's some little tips and tricks I've learned in using the device that have really helped with successful outcomes. I'll just give you one example, not to dive into the weeds too much, but consider the patient who has a thrombosed bypass graft or a thrombosed stent. We all know the failure mechanism for that is intimal hyperplasia, progression of disease, usually on the outflow side. And so one tip that I've, introduced that has led to very successful outcomes is, well, once you get your catheter and your sheath, et cetera, in place, once you've traversed the lesion and you find yourself in healthy blood vessel and you've confirmed that with an angiogram, I do my first 1 or 2 passes with the aspiration catheter with the Bolt 7 over the wire, because it leaves you in place. And, as you and I know and others, the most dreadful moment in an endovascular procedure is when you've crossed the lesion, you start to intervene, and then you lose your wire purchase.
Oh, God. Yeah.
Right? It's a nightmare, and you can't get back across oftentimes. And so I think that's a very key step for this aspiration thrombectomy is once you have your wire crossed, maybe just do that first pass over the wire to open up a channel, give yourself a little more wiggle room, a little more breathing room to then do the rest of the procedure.
Sure. And then sometimes too, don't cross that distal outflow cap. Use it as kind of a protection. And then, once you think you've cleared a lot of the proximal stuff, then go ahead and break through that. It's something that I do.
Yeah. You have to tailor your technique to what you're seeing you in front of you, what the patient is, and what their subsequent revasc might be.
Totally. So speaking of Limb Alert, now you've created this program at University of South Florida. What exactly is it? How does it work? And how are people alerted, and how has it affected these patients?
So when I took over as director of our limb preservation PAD program, one of the first QI projects we dove into was amputation reduction.
Okay.
And, for any of us treating peripheral arterial disease, it is inevitable. If you treat enough patients, if you're doing enough open or endo revascularizations, yes, you're going to have patients that get to the end of the road in their options or present to you in end-stage disease, and amputations are inevitable. When we started looking at our amputation population and really trying to learn from our own historical experience, we found that acute limb ischemia was a large contributor to that. And that message is the same at every major center and anyone who's doing complex vascular disease. So again, learning from stroke and STEMI, we sought out to create a standardized protocol, a standardized approach to these patients, whether they were coming in through the emergency department at one of our urgent care centers, through our transfer center, or even in-house on one of the wards or ICUs. And so it's a standardized protocol where if you're a patient presenting with any of the signs of acute limb ischemia, any of those 7 Ps, within a 2-week time frame, an automated alert is set, meaning that the ER, the vascular attending on call, the vascular fellow on call, the OR, the ICU, the IR suite, and our radiology department all receive this text or page alert. Again, similar to what stroke and STEMI currently do.
Yeah, exactly.
And the goal of that was to let all parties who could potentially be involved, let them know, hey, there's a patient here with an acute surgical condition. Get your thoughts in order, expect a phone call, and we will keep you appraised of what's going on. And so within that alert process, once let's say it's an ER physician, once they sound the alert, vascular is at the bedside in the first few minutes. There is a standard order set that we created to get all the basic labs, a rapid initiation of heparin and IV fluids. Prospectively, we're monitoring other inflammatory markers like CRP and CPK and even troponins at baseline to see if we can help get a better sense of how ischemic these patients actually are. And so it's a standardized alert, and all parties involved get notified. And the moment that is set, since we lead the alert process, we as vascular surgeons are then in complete control of which tests get ordered for imaging, where is the patient going for definitive therapy. And so it removes these occurrences of the patient who comes in with acute limb and it isn't recognized, and it's obviously a clinical acute limb, and you go to see him, but they're getting a 2 view of their ankle x-ray, which is completely unnecessary. So it's really trying to expedite that diagnosis and then allow us to expedite the management.
I mean, it's so true. You can have like a duplex and you wish you had a CTA, to kind of better define what the aortoiliac inflow looks like or other. But yeah, with your system, you get to know instantly versus something like in ours, I may know about the case or something overnight, or I get notified in the morning, or it's a delayed diagnosis.
And written into the protocol from an imaging standpoint, because it's a clinical diagnosis, but to your point, exactly, you need imaging of their inflow aortoiliac, their outflow. In the protocol, the only option that providers have for imaging is a CTA with runoff. It's either they get a CTA with runoff, and because it's part of a hospital-wide protocol, if you have a stroke patient, an acute limb patient, and a trauma patient, those images take precedence over anyone else waiting in the ER for a stat CTA. So we get to jump the line, but having that preoperative knowledge of what their anatomy is really important. And to harken back to something I mentioned at the beginning, a lot of our patients are failed stents and failed bypass grafts. They're failed prior interventions that we often know who that patient is. We often are the ones who operated on them, 2, 3, 4, 5 weeks ago. And so there's so many occurrences that we had seen in the past where patient was getting an ultrasound. They didn't need the ultrasound. I just operated on them last week. I know what their anatomy is, right? And so it's really, again, it's just to streamline their care, expedite their care, and then allow us as the interventionalists to reperfuse as quickly as we can.
Who initiates the alert? Like, is it the ER? Say this patient comes to the ER. Is it the ER doctor who's like, oh yeah, there's an alert system? How does that work? And what if they forget about it?
It's a mix. And so the triage in our emergency department, our main hospital, the triage is staffed by either one of the ER attending physicians or an advanced practitioner. And any of them, whomever's in the triage kind of area, can sound the alert. If it so happens that let's say the frontline provider is unsure if it's acute limb and they curbside one of us, we have enacted the alert. Because the importance of the alert is to expedite the care. But as we're monitoring this prospectively, when it gets sent out through the paging system, it also gives us that little reminder of, let's sure this patient is going into our research prospectively. Let's make sure we have eyes on them so that we can report on our clinical outcomes. And we've all embraced, Sabine, the endo first approach. And so if their anatomy and their prior surgical history, if it allows for an endo approach, again, we're embracing that use of penumbra and the computer-assisted vacuum thrombectomy. And similar to what their STRIDE data showed at 30 days, with the STRIDE data showing a limb salvage of 98%, we've seen the same things. We have data, we've had this in place for a little over a year now, and we've seen and reported amputation-free survivals in hospital of 96%, at 30 days of 95%, and even out to 1 year, we're a little over 80%. So our numbers, and I'm sure we're not the only hospital embracing this rapid approach, but we're the ones protocolizing it and reporting it and sharing our data. But our numbers and taking this rapid approach and this rapid debulking and utilizing the best available technology, which we confidently believe is the Penumbra Bolt 7 system, has led to outcomes far superior than historical numbers.
It's impressive. I mean, it's obviously successful. I mean, it's not an established, stroke and STEMI are so established in cardiology and neurointervention. I mean, how did you get this? This is like a new idea. It's very, creative. How did you implement it? I mean, that's the thing. How did you get buy-in from the ER? I find that must have been a pretty hard task to do.
Creating the protocol was a several-month process, and naturally it had to be a very collaborative effort. And so, for better or for worse, as we were the only ones treating the acute limb patients, we didn't have to get buy-in from other specialties, right? So we didn't have to get the IR docs or the IC docs to go along with the protocol because they weren't treating these patients up front anyway. But it did take some education and a lot of discussion with the emergency department. And so this was not created due to a lack of knowledge or success of the ER. Our ER physicians are fantastic. And we've looked at, I call their batting average, right? We've looked in this last year of what their, when they call the alert, how successful are they? And they're spot on. It's not 100%, right? But they are really good at detecting the acute limb patients. And so this was not to step on their toes or take their decision-making away from them. But this was driven from stroke and STEMI and trauma and these alert systems that are well-established nationwide of rapid diagnosis, expedient management. And this is one of these principal things in acute limb that time does matter. And so it was a lot of education. It was a lot of collaborative discussion about who could enact the alert, or what does it mean when this happens. And it took some convincing from the emergency physicians because as the frontline providers, there'd be times where they were a little gun shy and they were a little fearful of, well, I don't want to sound an alert and be wrong.
Yeah, I couldn't see that for sure. Yeah.
It doesn't matter. Call it. We would rather have you call and we decide that it's not correct than to miss it or delay it.
Exactly. Yeah. I mean, I bet administration loves it too, because in this day and age of turnaround time and, the ER wants to triage this patient, go on to the next, right? This is great because some of these patients can just be sitting there for a long time in the ER and waiting for a diagnosis. It sounds like you got your imaging, you got your team, and you're ready to go and take the patient and admit them to very quickly with this program.
I know it's not true, but I like to think that all practitioners follow evidence-based guidelines in medicine. But evidence does speak to all levels in a hospital, whether it's the frontline provider or the administration. And in developing the protocol, Sabine, we showed them, here's what our amputation rates have been yearly. Here's the percentage of patients that are requiring amputations due to acute limb. And here are the errors we've seen in their management, time from admission to vascular consult per se. And you show the hospital administration, here's the daily cost of someone who requires an amputation, what their total cost of care is. And with a protocol like this, again, learning from stroke and STEMI, if we can shorten the time to diagnosis and shorten the time to treatment and decrease the length of stay, be it in the intensive care unit or the surgical ward, it's at a benefit to everybody. It's at a benefit to the patient. It's at a benefit to the hospital system. We're in this age of healthcare where all hospitals seem to be overwhelmed all the time, and patients just keep getting more ill, and healthcare gets more fragmented. And so we made a really compelling argument from an evidence standpoint, from a financial standpoint, and from a service standpoint to the patient.
Yeah. And like you said, a lot of these patients have prior intervention. I think we're getting better and better doing interventions and getting people to keep their leg for longer and longer, that we're going to be seeing more and more and more acute limb ischemia, because essentially we've kept these legs longer than we did 5 years ago. Has there been anything, obviously in stroke, we have AI programs now, like Viz. In aortic work, I don't know if you've tried out the Viz aorta and other programs too. Do you think there's a role here where, they can combine with clinical diagnosis and combine with your Limb Alert program?
I think acute limb ischemia is one of those areas in vascular that's in critical need of a reappraisal. The Rutherford system is fantastic. It is a great clinical diagnosis, and it is absolutely correlated to outcomes. But we should evolve our thinking, right? And that's what we're trying to do as part of the protocol, is monitoring those preoperative markers, be it troponins, the other inflammatory markers, LDH, CRP, CPK levels. And I think in a prospective study and protocol like our own, or future randomized trials, which are desperately needed for acute limb, we can add in and pepper in all these other variables to get a much more complete picture of what an ischemic patient really is, regardless of Rutherford class. And I think it's in that setting, like to your point exactly, like we already have for stroke and we have it for aortic. The more information you have, the more applicable an automated AI-based engine can then be to help you define outcomes. So I think absolutely, we have the tools, we have the technology, the modern techniques with endovascular are really changing the landscape of how we treat these patients. It's then kind of incumbent upon us as the practitioners to, again, playing chess, not checkers, think forward, how can we use this data and this technology to then even further better our outcomes? But your point with the increasing number of patients with failed interventions rings true, right? We're in this era of vascular where best CLI and basal and these randomized trials are debating how we treat the chronic limb-threatened ischemic patient, CLI, and we're embracing more endo approaches for all states of disease. I hate to say it, but I say it to all my patients, nothing we do is a cure. We're buying time, and inevitably that treatment, that therapy is going to fail at one point, and you hope for the patient's sake that you catch it acutely, or that if they don't catch it acutely, that it doesn't lead to an amputation.
Well, if any AI company is listening right now, like Viz, you guys should definitely talk to Dr. Bailey here, because I think I love how you created this system at your hospital. I mean, it's way more advanced than I think 90% plus community physicians are practicing. I know if I had an acute limb, I'd like to be treated at the University of South Florida if it was my own leg.
So I gave grand rounds at the university a couple of years ago on acute limb ischemia, and I entitled it Acute Limb Ischemia, ... not another cold leg. That's how most of us see it. It's always that consult that comes in at 9, 10 o'clock at night, 2 a.m. Residents call you to tell you it's a cold leg. You know immediately what you're in store for that night. So if we can protocolize the approach to these patients, expedite their care. It makes it easier for us as practitioners, makes it a little less burdensome to try and get labs or heparin or other things done if it's standardized. And I truly think we're at that point in the care of these patients where we have to embrace the modern endovascular approaches. The STRIDE data that just came out had a limb salvage rate at 98%. That's outstanding. And it's a device, a technology that's embracing automated intelligence with their computer-assisted aspiration mode to really make it more efficient for us as the providers. And so newer technology like that, protocolizing how we approach these patients, and really giving as much care and attention to acute limb as we do to other facets of vascular care, are what going to translate to long-term good outcomes and, some change in the historical rhetoric.
Definitely. I mean, you're right. We're the data and the stuff we're referencing before STRIDE and all this is 30 years old. I mean, it's like we're working in 1990 and thinking, okay, the landscape has changed. I'm looking forward to all this data that you're going to produce, hopefully maybe some standardized protocols that are updated and get some more uniformity between all of us endovascular specialists to how we treat it. Because yes, there's a lot of ways to skin this cat. This uniformity is tough. What about the future? Anything about, we've talked about the computer assisted devices. Is there anything else on the horizon or in the future that you can see in this field?
I think acute limb ischemia as a vascular and endovascular topic and disease state is lagging a little bit compared to other organ systems, right? Carotid disease has advanced, right? We've gone from traditional endarterectomy to several different ways to do percutaneous stenting, flow reversal, et cetera. Aortic disease has almost largely become endovascular, save for the patients in extremis or the anatomy that you can't custom build a device for, which is the rarity nowadays with the advanced technology and physician modified endografts. And there's the ongoing debate in the chronic PAD realm of open versus endo and when is best. And right, depending upon which side of the pond you live on, the data supports one way or the other. And acute limb is lagging a little bit, right? To what we just spoke about, that randomized trials are 3 decades old, using technology that is not inferior, but for many of us, put in a lytic catheter and is not the first line or first thought we often have in treating these patients. I'd say it's become more of an adjunct than anything. And what's really needed with acute limb ischemia, Sabeen, is a new randomized trial. You look back at the randomized trials, be it STYLE or TOPAZ, and they were all flawed. No one of them was a true open versus endo approach. How can a trial claim it's a direct comparison of open versus endo when the endovascular arm, 50 to 60% of them ended up having an open revascularization, right? And or excluding embolus as a source of embolism in your randomized trial, or limiting to a single treatment. So I think in the horizon, the next 5 to 7 years, that's where we should be headed. I know our institution with our protocol and other institutions around the country who have embraced this endovascular first approach, we are eager to do that. We are combining data sets, combining our recent modern endovascular experience, embarking on fast track protocols, prospectively studying, in our case specifically, the Volt 7 device to look at that as a first or definitive adjunct for acute limb. And this swell, right, this wave that is about to crest is all building supportive data to then doing a supported multi-center randomized trial. That's where we should be headed.
Well, that's great. I mean, I encourage all of our listeners, if you're thinking about starting a Limb Alert program, to reach out to Dr. Bailey here. I know I'm going to probably ask you some more questions offline and everything, because I'd love to get this going in my program. So, Charles, thanks for being on the show. That was really great. A lot of information, and really enjoyed having you on.
Well, Sabeen, and to Backtable Podcast, thank you kindly for the invitation. This is something I feel passionate about, something that all of us, regardless, especially as interventionalists, we have to manage, whether we want to or not. And so the more thoughtful, the more direct, more protocolized, more efficient we can be, will naturally lend to better outcomes for our patients. So I really appreciate the opportunity to share this with you all.
Absolutely. You're doing awesome work, man. Keep it up.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_backtable on Instagram, Twitter, or LinkedIn. Backtable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manveer Singh Sabri.
Administrative support provided by Jamila Kinnebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.